Mrs. X, 27-year-old from Kanyakumari, accountant by occupation, who has an education qualification of MBA, belonging to upper middle class according to modified Kuppuswamy scale. Her husband is Mr. Y. She is a Premigavida. Last menstrual period is 10/3/24. So her EDD falls on 17/12/24. Gestational age is 37 weeks and she is a booked pregnancy. Chief complaints: Premigravida at 37 weeks of gestation with gestational diabetes mellitus on oral hypoglycemic agents has come to OPD for routine antenatal visit and admitted for safe confinement. History of present pregnancy: first trimester, conceived naturally. Pregnancy was confirmed by doing UPD at home after 10 days of missing periods. History of nausea and vomiting present. No history of fever with rash. No history of breathlessness. No history of difficulty in doing day-to-day activities. And no history of bleeding PV, pain abdomen and burning micturition. No history of radiation exposure. No history of any other drug intake. BP measured and found normal. All other investigations normal. Dating scan corresponding to gestational age. NT scan done and was found to be normal. Double markers done and normal. Folic acid tablets taken. First dose of TT taken. Weight gain in first trimester is 2 kg. Second trimester, patient started to notice abdomen enlargement. Quickening felt at 20 weeks. Nausea and vomiting reduced. No history of bleeding PV. Quadruple test done and was normal. Anomaly scan was done and no anomalies were found. No history of pedal edema, headache, blurred vision, right hypochondrial pain or decreased urine output. Fetal echocardiograph was done and was normal. Blood pressure measured and was normal. All other routine investigation results were normal. Maternal echocardiograph was taken and found to be normal. GTT was done at 25 weeks of gestation and blood sugar values were found to be elevated. Oral hypoglycemic agents was started and diabetic diet was advised. Iron and calcium tablets taken. Second dose of TT taken. Weight gain in second trimester is 4 kg. Third trimester, fetal movements were well perceived. No history of pedal edema, headache, blurred vision, right hypochondrial pain or decreased urine output. No history of bleeding PV. Growth scan with Doppler was done at 32 weeks and was normal. Iron and calcium tablets continued. Patient continued to be on oral hypoglycemic agents for gestational diabetes mellitus and regular sugar monitoring was done and the results were within normal limits. Weight gain in third trimester is 4 kg. Diabetic diet was advised. Menstrual history: menarche at 14 years, regular 30-day cycles with 5 to 7 days of flow, changes 2 to 3 pads per day, no history of dysmenorrhea and no history of passage of clots. Marital history: married for 1 year, non-consanguineous marriage, no history of use of contraception. Past history: not a known case of diabetes mellitus, hypertension and no history of epilepsy, bronchial asthma, tuberculosis, heart disease, thyroid and renal disorders, no history of previous surgery. Family history: both her parents, father and mother is diabetic. Personal history: mixed diet, normal appetite, adequate sleep, normal bowel and bladder habits, no history of alcohol and smoking.
Now I am going to continue with general examination. The patient was conscious, cooperative and oriented to time, place and person. Moderately built and well-nourished. Pre-pregnancy weight was 74 kg and her current weight is 84 kg. So the weight gain was 10 kg. Her height is 152 cm. So on calculation, the BMI was 32.03 kg per meter square. No pallor, icterus, cyanosis, clogging, lymphadenopathy and edema. Breast and thyroid examination was normal. Vital stable and are within normal limits. Another systemic examination: cardiovascular system, S1 here, no murmur. Respiratory system, bilateral airway present, no abnormal breath sounds, no added sounds. Central nervous system, no neurological deficits. After informing the patient and getting consent and after emptying the bladder, obstetric examination was done and on inspection, the shape of abdomen is longitudinally distended, transfull, all quadrants moves equally with respiration, linear artery, striate bladder is present, umbilicus is in midline and flattened, no scars, sinuses and engorgement is present. And on palpation, symphysium fundal height was found to be 36 cm and the fundal height corresponds to term. And on fundal width, soft irregular has come to OPD for regular antenatal visit and got admitted for safe confinement. Provisional diagnosis is gestational diabetes mellitus complicating pregnancy.
A very nice presentation. This is a summary. This is a diagnosis because in previous case also I did not put the diagnosis. Is this diagnosis complete? So now complete your diagnosis. Complete your diagnosis. There are two terms which you need to understand. One is a summary and one is a diagnosis. Okay? So whenever examiner asks, he generally asks the diagnosis. So tell me the diagnosis.
Primary gravida at 37 weeks of gestation is diagnosed with gestational diabetes mellitus complicating pregnancy on oral hypoglycemic agents.
Something more to be added.
With cephalic presentation and
Live fetus, dead fetus.
single live fetus.
Okay? So just repeat it again.
A 27-year-old Mrs. 6 diagnosed with gestational diabetes mellitus with single live fetus and cephalic presentation on oral hypoglycemic agents come to
So you have the sequence should be right. Okay? 27-year-old primary gravida with 37 weeks of period of gestation with single live fetus with gestational diabetes on OBG. Right? So do you think this patient needs admission?
No, ma'am. She is an oral hypoglycemic agents and the values of
Controlled, so she doesn't need admission. So okay. Now we go back to your history and we have a target to finish whole your GP. So go back to your history. Okay, go back, fast. You people make very nice PPTs. I really appreciate that things. So much efforts have been put towards making these PPTs. Yeah. Okay, so you have started with the first trimester history because there was no chief complaints as such, right? So first trimester you told all these things. Next slide. So in this case, she was not tested with OGTT in the first trimester.
In the first trimester it was normal.
It was normal, it's not written here.
DEVI, routine investigation, DEVI used.
Nay, where it is written?
All
All other investigation includes what? That is very important. So if it has been done, it has to be written or told to us that OGTT was done. Now tell me that anti-scan, does the patient tell you that my anti-scan has been done, my dual marker was done?
she had reports.
No. That is the point which you have to see. You are not allowed to see the investigation or the files whenever you are being given the case. Okay? So you don't need to write down NT. If she is an educated female, she tells you on a leading question that any ultrasound has been done, dual marker has been done, it is okay. But otherwise, if she has not told you, you don't have to write down anti-scan and dual marker has been done. Otherwise, this question will be there. Did she tell you? Right? Second thing. Next slide. Next slide. Okay. Now tell me, was there any need of quadruple marker in this case? Was there any need of quadruple marker in this case? Anyone else? To rule out congenital anomalies, you did a quadruple marker? Everybody, all of you raise your hands. Okay, stand up and tell. For chromosomal anomaly, you got a quadruple test. And what is for dual marker? Okay, we will not waste time here. So if you have done NT plus a dual marker, there is no need to go for a quadruple marker. NT plus dual marker has got a better sensitivity specificity. So there is no need to go for another screening test in a second trimester. So if you have told your examiner that NT plus dual marker has been done, don't tell her that quadruple marker. Okay, so there is no need of another screening test in a second trimester if you have gone for a NT plus dual marker. Now again, you have gone for a fetal echocardiography. For what? All these tests have been done or you have just written down? No, these have been done. This have. So what you not done? So is it needed? Fetal echo needed? Fetal echo needed? Needed? Okay, now we go back. OGTT on the first trimester was normal. She was a case of GDM now. She is not a case of overt diabetes mellitus. Now I ask you what complication you anticipate if you are getting this thing done, and was she prone for that? Cardiac anomalies occur in which type of diabetes?
Overt diabetes.
Is she a case of overt diabetes?
No.
When she is not a case of overt diabetes, why to go for a fetal echocardiography? Always remember, this is a neat PG question also. They give you what complications can occur during gestational diabetes mellitus, and they write down fetal congenital anomalies. And that is the thing which you need to take, that it cannot occur. So gestational diabetes mellitus, you cannot get a congenital anomaly, but yes, in 22M there are chances of increased chances of congenital anomaly. So there was no need of getting a fetal echocardiography in this case. There was no need of getting a quadruple marker. If she has got done and you are telling, you need to know the answer that it was not needed. You are telling because it has been done. Patient is telling this is a part of your history. But it is not indicated in this case the quadruple marker and the fetal echocardiography. Right? Next. Now the next question comes, what are the chances when the patient has an increased chances of congenital anomaly in cases of diabetes? What is the HbA1c level which you take as?
More than 10.
So it is more than 8 when chances are increased. More than 10, see, once it is between 8 to 10, it is around 6 to 8%. Once it is more than 10, it becomes a 12%. If it is more than 12 to 15, it becomes a 15%. Less than 8, there are very less chances. Less than 6.5, it is equal. So it is more than 8 when it increases the chances of congenital anomaly. Why there occurs a congenital anomaly in diabetes in pregnancy?
During organogenesis.
During organogenesis, what happens? Why the diabetes makes the patient more, or a female more prone for congenital anomalies?
Hyperglycemia.
What happens in a hyperglycemia?
Free fatty acid.
Yes? Yes, that is the answer. Because hyperglycemia causes a release of the free radicals, and these free radicals are going to affect the DNA methylation, and that is causing the problem of the congenital anomalies. And that is the theory behind the transgeneration transfer of the diseases. Okay? So now, once we come here, again OGTT was repeated. Now my question is, how do you perform OGTT?
After overnight fasting, 75 grams of glucose is 99.
You are slightly confused here. So which test are you talking of? Now, which test are you talking of? How many types of OGT do you know?
One-step approach.
One-step approach? Okay. Okay. What all OGTTs you know which are used for a screening test?
For first time is the screening DEVI.
First is DEVI. Second?
One-step approach OGT.
One step, all are one step approach. DEVI, you told me DEVI right now? So which test OGTT you told me?
It is WHO.
You told me WHO?
Yes.
No, you didn't tell me the WHO. You told me the IAPSD. What is the full form of IAPSD?
International Association of Diabetes and Pregnancy
Study Group. What is the full form of DEVI?
Diabetes and Pregnancy Study Group of India.
Of India. Okay. So how do you perform a DEVI test? All are one step?
Irrespective 75 gram of glucose is given and only postprandial value is taken in
Which postprandial values?
2 hours postprandial.
2 hours postprandial values. How much water do you use to give?
300.
300 ml. 300 ml you give in how many minutes?
15 to 20.
Huh? 300 ml. Dark. 300 ml. How many minutes you give? Yes? 5 minutes. Is it easy to drink in 5 minutes?
15 to 20.
15 to 20 minutes. And then when do you take out the sample?
2 hours.
When do you start your clock to take out the 2-hour sample? After giving, before giving, between, because you have asked your pregnant female to take in 20 minutes.
After giving.
No, it is the first step. It is the first step when you take out just switch on this clock for 2 hours, because this is the first response of insulin which is happening. Okay, so can we repeat the 75 gram test for DEVI that you give 75? Okay, how do you make the 75? Are you getting this glucon D 75 grams? How do you find out this 75 gram glucose? You get a 100 gram box. Have you ever seen? Have you ever seen? So you don't have a glucose available with you. You don't have a glucose available with you. Can you use sugar? No. Why not? Glucose ज़्यादा है, sugar कम है. What is more sweet?
Sugar.
So you cannot use, okay? Because you want a pure anhydrous glucose. Even the glucon D which you are giving 75 gram is not right. It has to be 82.5 because it is being said you need to use an anhydrous glucose. If you read it, a word anhydrous glucose is written. Okay? So anhydrous glucose 75 gram, you have 100 gram of box. How will you make it to 75 grams? Because your pregnant patient management is going to depend upon this single test. How are you going to make this 75 grams? So, 1 spoon amounts to 5 grams. You will remove 25 grams and rest of the 75 grams to be given to patient. Dilute it 1 to 1.5 glass of water, because you are not going to say 300 ml water, you dissolve it. So 1 to 1.5 glass of water, you dissolve it. Drink the glucometer to test this?
No.
Why no? Why no? Whole organ and NHS has based on glucometer only. So you can use a glucometer to test it. Although the venous blood glucose sampling is the best method, but glucometer can be used. Okay, so this is regarding the DEVI. How much should be the values for the DEVI?
Less than 140.
Less than 140. If it is more than 140, she will be labeled as gestational diabetes mellitus. If it is more than 200,
diabetes mellitus.
Over diabetes. If it is between 120 to 140,
impaired glucose.
Gestational glucose intolerance. Now coming to IAP-PST, you have got 3 values. Overnight fasting, similar way, you will take out 3 samples, 0, 1, 2. Okay, so how many values you want it to be normal or abnormal?
One value.
You will label the patient, one value. You will label the patient, gestational diabetes mellitus. Now here you have written, why I have taken so much time, you have written oral hypoglycemic agent for this. What is the first step of management of gestational diabetes mellitus?
Based on values, if it is less than postprandial value, if it is less than 120, you can manage with medical nutrition therapy. But if it is more than 120, within 2 weeks, we should start.
We should immediately start the medicine. No. Whenever you are diagnosing your patient as a gestational diabetes mellitus, then first you have to give a medical nutrition therapy to your patient. So both of the things have been started simultaneously. It should not be done. First you have to give a medical nutrition therapy. In a medical nutrition therapy, how do you decide upon the diet and the calories intake?
Based on BMI of the patient.
Only BMI or something else? Physical activity. There are 2 components which need to be included. One is the pre-pregnancy BMI and the physical activity, according to which you have to make her diet chart along with exercises. Okay, for how many weeks you give a medical nutrition therapy?
2 weeks.
2 weeks. After that, what are the tests are you going to get done?
Fasting blood glucose and postprandial 2 hours.
Fasting?
Blood glucose and 2 hours postprandial.
Only one value?
2 weeks once.
After 2 weeks, patient has come to you what sugar values you want so as to decide upon whether drug has to be started and not to be started.
2 hours postprandial.
Only single? Ideally, 4 values to be taken. Fasting and post meals, that is post breakfast, post lunch and post dinner. And what is the target blood sugar values whenever you are starting up on the patient on a treatment?
Fasting less than 95, 2 hours postprandial less than 120.
Yes, okay. Right? Okay. Once the patient has been diagnosed with GTT, you have started, what next if she is not controlled?
We should start with oral help. If it is less than, we should start with oral hypoglycemics.
Why oral hypoglycemics? Why not insulin? What is the drug of choice for the treatment of the gestational diabetes or over diabetes? Very good. Insulin is the drug of choice. Insulin is the drug of choice. What are the indications? Now, this is not written. Where do you start the oral hypoglycemic agents? So, when anyone want to answer, someone when do you want to start oral hypoglycemic agent and which one?
More than 20 weeks, if the postprandial blood sugar is not controlled, we will start.
When will you like? Insulin is the drug of choice. You have to give insulin, but we don't give it. Why we don't give it?
It can lead to fetal.
Whenever the patient is non-compliant, she is not ready to take, the sugars are not that high, right? Or if the patient was already taking metformin, due to any of the reason, maybe somebody has continued because she was a case of PCOD, infertility, or she was already taking, or any of the reasons. So you don't need to stop, you can continue. A most important thing, you need to see the compliance. Insulin is, our patients are not that educated that they can take this insulin. So, for any practical thing, or the insulin is the drug of choice. Okay? So, always remember this thing, insulin is the drug of choice, but whenever the patient is not compliant, you are going to start with the metformin. Do you know the doses of metformin?
500 milligram starting dose. We can increase up to 2000 milligram twice daily.
2000 twice daily.
500 milligrams twice.
So you can start with the 500 milligram, can give twice or thrice daily and can increase up to the 2.5 grams. And now, how will you monitor your patient now? She is 37 weeks, but she has been started on 25 weeks. How will you monitor your patient?
7 times.
No, okay. Sugar monitoring. So now this is 25 weeks. We have started on a OHS, as you told me. Now what has to be done? You have to make a plan of your pregnancy. Na? Okay? So when are you going to call? What all things are you going to do in your pregnancy?
Which is class A to the gestation diabetes. We have to monitor her twice weekly till 38 weeks for fetal surveillance.
So twice weekly are we going to do a fetal surveillance?
Yes. In
Twice weekly? No. This is too much.
2 weeks once.
So anyone who wants to tell me what is your plan for pregnancy, because this is a long journey for a female and for you also. So you have to make a plan for each and every pregnancy. So you have to plan at how many weeks you are going to call patient and what all tests you are going to do in your, that chart has to be written.
Blood sugar monitoring is done 2 to 4 weeks once, and for fetal surveillance 2 weeks once, and other urine investigations should be done, like urine albumin.
How many visits are needed for a routine antenatal patient? What are the recommendations of the Government of India and what are the recommendations of a WHO? WHO says 4, Government of India says 8. Right? This is. Now you can increase upon according to the disease or requirement of a patient. If she comes to be gestational diabetes, next you call her at 28 weeks, you have diagnosed 26 weeks, you have given an MNT. Okay, you have to tell her that. We have given an MNT, we will call her at 28 weeks with the fasting and post-meal blood sugar values. If those are normal within the range which you have told just now, then it is okay. Otherwise, we will add her the drug, and as we have to see the control of the drug, whether it is an insulin or a metformin, we will call her after a week's time and then see the sugars. If the sugars are going normally, we will call her at 2 to 3 weeks interval. The ultrasound to be done at 32 and 36 weeks. Right? What do you have to assess in the ultrasound?
Fetal growth,
So now you have to tell me the fetal complications which can happen. Macrosomia. Okay. What is the difference between a macrosomia and LGA? These are the two common terms which are being used.
Macrosomia, the fat deposition is mainly around the trunk and shoulders.
This is the PG question. What is the difference between the LGA and the macrosomia? What is the difference between the macrosomia and LGA, large for gestational age baby? The terminology itself tells you. The LGA means you are calculating the weight according to the gestational age and you are using a centile. So you need to chart it on a growth, and whenever the weight of the baby is more than 19th centile for that gestational age, this is a LGA baby. But macrosomia is an absolute weight, and for an Indian baby it is more than 4 kg. For Western countries it is more than 4.5 kg. Got it? So this is a basic difference between macrosomia and LGA. So during pregnancy we use the term LGA and we chart it on a growth chart. You know the growth charts? We have to chart the growth of the baby in the growth curve. And we have to see how the baby is behaving for the control. One thing you are seeing the macrosomia or a LGA. Second, AFR. You have to see the complications of pregnancy. So polyhydramnios you have to see. What else?
Fetal growth restriction.
FGR. If you have too much control, patient can land up into fetal growth restriction, or if it is a case of over-diabetes, this can occur. What else can occur in this patient for which you are worried, and now we have to add up our investigations?
Preterm labor.
Preterm labor, very good. And why the preterm labor is occurring in this patient?
Because of maternal hyperglycemia, fetus also has hyperglycemia, so there is polyuria.
Polyhydramnios. Or why preterm labor is occurring?
Infection.
Infection can occur. So infection can travel from which place? Mainly
Lower
genital tract and the urinary. So you have to send investigation regularly. Maybe every visit 4 weekly urine RN has to be there, and you ask for the itching. Which infection is common? Vaginal infection? Candidiasis. So patient might complain of this infection. So you have to see that sugars are controlled and she is not having any vaginal infection, because vaginal infection, polyhydramnios, macrosomia all can lead to preterm labor. What else can occur? A very important deadly complication.
maternal preeclampsia.
Preeclampsia, and we all are worried with that complication. Intrauterine death, fetal death can occur whenever there are a lot of fluctuations or there is very high blood sugar. So you need to be very careful. Okay? So with and what else? Simultaneously, so every visit you have to see
Urine protein.
pallor, blood pressure and growth. Ultrasound at 32-36 or according to your need. ठीक है? Hemoglobin to be done 1 in each trimester and according to the need. Urine albumin to be done, or what else?
Fundus examination.
Fundus examination need to be done. That is more important in cases of over diabetes. But yes, in gestational diabetes also we get a fundus done. What else? Now she is 37 weeks. She is on OBG. What is your plan?
Her sugar values are within control. So we will observe 3 to 4 weeks.
So 37 weeks and we will watch for 3 to 4 weeks to go her to 41 weeks.
No. Until 30, if there is no fetal complication and there is no
case of gestational diabetes, controlled on a diet, you can take till 40 weeks. If the patient is on drugs, gestational diabetes mellitus, on drugs, controlled, take till 39 weeks. If she is on insulin, OHG not controlled, think of termination at 38 weeks. What are the complications which can occur in the neonate?
Prematurity, fetal respiratory distress syndrome, hyperbilirubinemia, polycythemia,
and
hypoglycemia,
hypocalcemia, hypomagnesemia, hyperbilirubinemia, polycythemia. So all 8, I think these are 8 number complications of the fetus you need to know. And there are not many things gestational diabetes, because we have not very high incidence of diabetes in pregnancy. We need to know as an undergraduate student also, there are so many things still left out which we need to know and which can be discussed. How the insulin is being given, what are the insulin to be used. So all those things we have covered the management part, a slight amount of management, not complete management, but these are the things which you need to know. Gestational diabetes, I think it's a very common in this area also. So we need to know each and everything regarding. Yes, dietary advice. That you just completed. What is the mean composition? What is the carbohydrate, fat, and the protein composition?
Carbohydrate 40%, fat 40%, protein 20%. Meal is divided into 2 to 3 snacks. In breakfast, the calorie intake should be nearly 10 to 20%. For lunch, it is 20 to 30%, and dinner it is 30 to 40%. For each snacks, the calorie intake should be 10%. Here the patient is overweight, so her calorie intake should be 22 to 24 kilocalories per day.
Very good. And a rough thing is that a female should divide her thali in a 5 parts, and you tell her that this thali, I don't know what to say, a level thali which is used, edge is there, so her food should not go above that edge. This is a rough calculations you have to divide. There should be different 5 colors of the food, so that she will include a green leafy vegetable, she will have yellow foods, white and rice and whatever next thing you have, dal and everything, and it should not go beyond the edge of your thali. And the way you told the division is very nice, absolutely correct. So thank you, I think this is more than enough for you.
Thank you.